just we just talked about the importance of excuse me, of eye care. And obviously that's critical for those that, what did we say had to be the level of deficiency? Which House-Brackman level did you have to mostly worry about? Anybody?
Sorry, I didn't hear your question.
No, so eye care, right? So we talked about the concern about eye care.
Yes.
Back. But what level of deficit on the House-Brackman scale are you mostly concerned about? Which levels would you be more concerned about being more stringent about eye care than others?
So anything worse than a House-Brackman 3, you worry about eye care because they're unable to close their eye, even with maximal effort. So any score higher than House-Brackman 3, you need to talk about tapping the eye on the side at night, using the natural tears, the lubricating gel, and then a wet chamber to try and keep the eye moisturized, because they can get corneal abrasions and keratitis due to exposure.
Right, exactly. And you have to, it has to be volitional closure, right? So I've always had this interesting, Brad, if you have comments on this, whenever I've done combined cases of neurosurgery, if there's been a facial nerve weakness after, there's always, and again, I'm not picking on my neurosurgical colleagues, but it's always interesting that there may be some interpretive variation in the House-Brackman scale where they may be beyond a 3, but gravity assist closure to the eyelid is misconstrued as maybe a 3 when it's actually a 5, maybe. So I think the key is you have to be very keen in looking at the exam and saying, is that a volitional closure, not like a gravity assist? Does that make sense?
Yeah.
Yeah, it has to be meaningful eye closure. You can't just be like, this slow lag time where the lid slowly closes down. Okay. All right. So that said, as we move into this, so you have this 35-year-old who comes to the clinic, sudden onset facial weakness, diminished brow elevation on the right, diminished oral commissure elevation, closes the eye incompletely. Okay. Has no other signs or symptoms. Is electrodiagnostic testing warranted in this case? Why or why not? And I can't see you guys on the screen. But I'll throw it out to the group.
Can you see us now?
I can. Yeah. So gift, is that what
That's gift, yes.
Yeah. Yeah, you guys are, it's easy to hide with the screen off. I can't tell, I can't pick on you appropriately with the screen off.
Let's see. Yeah, so I would say electro diagnostics at this juncture probably is not warranted. This is weakness of sudden onset with no other focal neurology, and we already can give the patient a House-Brackman probably of 5, maybe 6. I don't know when you say his hair, right? Incompletely, so there is some movement. So I'll probably say House-Brackman 5.
Okay.
I don't think I'll order electrodiagnostics at this junction.
Yeah, so it's good. So that's really important, right? So that the stem here, well, this would be equating to your exam, right? So if you're at the bedside and you're examining this patient and you see some intact facial function, which this little stem says that there is some function, right? And you're right, can't completely close the eye. So at least probably a 4 or higher. So definitely not a 6, right? Because there's mobility. Not a 3 because they'd be closing the eye. So you're thinking 4 to 5. I agree. So electrodiagnostic testing would not be warranted here, right? Because as we know, and this from our guideline from 10 years ago, which is interesting. We just had the first meeting for the updated guideline. So it's really going to move along pretty quickly. We'll hopefully have a whole updated guideline within the next year, a little over a year, which would be pretty great. But anyway, so you should not perform electrodiagnostic testing in someone with Bell's with an incomplete facial paralysis, because this tells you that there's still, despite the insult, there's still residual function, right? There's still some level of function that would not be warranted in testing, because it's not going to add to anything that you would already do. It tells you that the nerve still has function. And so that's the key here. So when you make your House-Brackman grade or your functional assessment, this kind of is an intuitive thing where you'd realize whether or not that's going to be warranted or not. Now, if you do not see any discernible volitional movement, okay, then the physiologic testing would be indicated at that time, because now you're looking for some kind of prognostic value, right? And also to see truly, maybe it's not discernible to your eye that maybe the nerve is still having some function, okay? Now, what we're going to do, we probably won't exhaust this here because it's a whole nother level of topic, but maybe in 3 weeks after the residents speak, we can do a facial nerve talk, okay?
Okay.
Would
Yeah,
that
that sounds.
We'll do an entire anatomic lecture on the facial nerve and injury, and we'll do a much more deeper dive into the actual logistics of testing, ENOG, EMG, all those things. So why don't we just, because the course of time here, we won't be able to do all that as a separate talk. How's that sound?
Yeah, that sounds good.
But one important caveat here is questioning. So let's say this person does come in and they're within 72 hours of this current clinical scenario, and there is no discernible movement. And so would you rush them off to the physiology lab now? Or is there any timing consideration for when you would perform the testing?
So it depends on what the type of test that you're interested in. Commonly, the electronystagmography is done, but we don't do it within the first 72 hours because of Wallerian degeneration. So I wouldn't do it immediately. I would wait and then compare the affected side, the action potential on the affected side versus the normal side to see the percentage of degeneration that we have. But I wouldn't do it within the first 72 hours. I would wait at least day 3. Between day 3 and 14 is when you do your electronystagmography.
And so which one do you start off with first? Do you do EMG? Do you do an ENOG test? And we won't get too detailed into it. We'll talk later about this, but what's the difference between the two?
So
what's an ENOG? What does that do?
So the electronystagmography, you're checking for the compound myogenic action potential in the nerve, and you're comparing that to the opposite side. And you want to know by how much it has reduced. So you're comparing the potential on the affected side to the potential on the normal side, and you're trying to find the percentage decrease in the potential in the muscle. While the electromyography, you're looking at muscle contractibility or muscle contractibility to tell you how much of the electro potential is getting conducted in the nerve. So the electromyography has no role in an acute setting. We usually will do it much later when we are looking at how much of the nerve is still functional and what our reconstruction options are for the nerve. While the electronystagmography.
So is it neuronography?
Yes.
No.
Yeah, thank you. Yeah.
Neuronography.
There you go.
Neuronography.
Sorry, I didn't want to correct you there where you're still talking. Yeah.
Neuronography.
Okay.
So we'll do it to compare the action potential within the nerve and compare that to the opposite side. And our cutoff is if you have a degeneration of more than 90%, it also gives you a bit of prognosis. it's a worse prognosis if more than 10%. If you're only less than 10% has the worst prognosis when you look at the long term with recovery, while more than 90% has a better prognosis in recovery for Bell's palsy.
Okay, so what's the fundamental difference between ENOG and EMG though? From the patient's perspective. This is sort of a what am I thinking kind of thing, but fundamentally, what's the difference between the two? So if you have two patients sitting there, one is getting ENOG, one is getting EMG. What's the fundamental difference between the two?
One is
If
testing the
Gift is there,
nerves.
oh, sorry. Let's see if one of your colleagues. Let's kick it over to your colleagues.
So I can try to answer that. I think for electroneuronography, you are literally testing the nerve, and then with myography, you are testing the output, the action potential from the from the muscle contraction.
Right, but but getting back to how are you doing that? So I guess sorry, I'm trying to sort of bait you into getting the answer. What is the like if you had two patients sitting there, how would you instruct one of them? How would you instruct the other? What would you say to one of them?
Oh,
What would you
okay.
say to the one who's getting, what would you say to the one that's getting ENOG? And what would you say to the one that's getting EMG? And hang on, Amina, hang on, hold on. Let's kick it over to your other colleagues. I can't remember who else is there. Sorry.
So this is Quincy.
Oh, Quincy's still there.
Remember
Sorry, Quincy, I can't.
Yes, I know Helena did come closer.
Yeah.
Helena is new. She's one of our new registrars that just joined us. You'll probably meet her when you come down in October. So she'll be starting her ENT block with her. We need to talk so that faces you.
Oh, great. Hi.
So that's Helena. She's from Namibia.
Oh, great. Excellent. Well, nice to meet you. So Quincy, then let's ask Quincy. So if you have two patients there, one's going to get ENOG, one's going to get EMG, what do you say to each one of them just before the testing? What are you going to tell them?
I think you're going to ask for the EMG, you're going to ask them to make a grimace or a smile. And then you're going to be measuring to see if you get an impulse on your monitor. I'm not sure about the ENOG one though. I'm not sure.
Right. Okay. So, all right, good. That's good though. So far, you're halfway there. So, how about Gift or Amina? What do you guys think? What are you going to say to the? What are you going to say? What do you say to the ENOG patient?
So the ENOG patient, we stimulate the nerve. We are stimulating the nerve, while the myography patient is the patient working to contract the muscles, and then we will measure how much is contracted. In ENOG, we actively stimulate the nerve.
So one is volitional, one is non-volitional, is what I'm getting at, right? So ENOG is just like it's far field electrophysiology, right? You're basically, well, not far field, but it's you're on the surface of the skin and you're providing stimulation to the nerve, right? The patient doesn't do anything. They just sit there and you are stimulating the nerve near the stylomastoid foramen. And the idea is you're trying to provide direct stimulation to the circuit, and then looking at the affected side versus the intact side and looking at a fundamental difference. And again, we'll go through this detail when we do this in a couple of weeks. The EMG is volitional. Now you're telling the patient, okay, now make an effortful volitional facial movement. And you're trying to measure motor unit potentials with EMG electrodes that have been impaled into the facial musculature, right? And that tells you completely different information about the health of the nerve, and we'll talk more detail about that. And so the timing on that is critical. Usually people will do EMG about 10 to 14 days after an insult. But to allow for that degeneration or that change to occur, depending on the health of the nerve and the health of the motor unit potential. So we'll go through that in more detail. But those are fundamental differences that's really important because you don't usually jump right to an EMG if the enog, which is essentially not, quote unquote, non-invasive. You can get a lot of information quickly about that and then say, oh, okay, no, that looks pretty good. It's not greater than 90% difference. Maybe it doesn't warrant an EMG, instead of putting needles in someone's face and these types of things. So we'll go through that in more detail, but keys to remember here. One is you don't do electrodiagnostic testing on someone who has partial or paresis, right? We define that as paresis rather than paralysis. And the fundamental difference between enog is non-volitional versus a volitional test in EMG. Okay. And we'll go through all those details later with things like fibrillations and motor unit potentials, this type of stuff. And what does that mean? We'll go through all that. Okay. Sound good? Do you guys have, I'm not sure in Cape Town, I can't remember what Tashneem said this. Have you guys observed any electrodiagnostic testing there?
No,
No.
Okay.
the only session of testing we do
Yeah.
is the intra-op monitoring. We don't do this
Yeah,
test.
right. Intra-op monitoring, which is, that's basically an EMG, right? When you put the NIM monitor in, that's you're
Yeah.
utilizing an EMG, right?
Mm,
Okay.
mm.
It's basically you're impaling. Yeah. Yeah. Okay. All right. So just something to think about here. And then along on the heels of that, let's go through this a bit more here. So 45-year-old followed by primary care for 12 weeks. Okay. So that's about 3 months, right? Calls your office, believes their facial weakness is not improving. Now, remember, what did we say before at our last talk about the natural history or progression of Bell's? What is the natural progression? Typically, if you took 8 out of 10 people, you took 10 people, 8 of those roughly would probably do what if you did nothing? What would be probably
So
the
the improve.
right to
80%.
to what level?
To a house Brockman about 2 to 3.
Yeah, maybe
If you
even
can,
one or two.
maybe.
Yeah. Yeah, even in the absence of steroids, some people in the old studies have shown that, which is interesting. So, and then a lot of those studies show that you should see an improvement or a move toward an improvement within 3 months. So that's where a lot of this data comes from. So, but she's saying by 3 months that it's not getting better. And the initial eval, which did not include imaging, was negative. Okay. So again, you've done your due diligence, you've ruled out any other causes. Okay. And there's no significant medical history or other events. There's been no change in her paralysis since the 3 months ago. And she does have complete paralysis, right? Okay. So what would you do next at this point? Gift, what would you do next?
Yeah, so I would say this patient has like house Brockman 6 and days. It's been there for 3 months. I think he's one of the patients I would consider doing electrodiagnostics in terms of one to at least see if there is any residual function in the nerve and also to prognosticate in terms of recovery.
Okay. Okay. Anything else?
I'm concerned about her red and itchy eye. Usually the redness and itchiness are early signs of keratitis. So I'll be concerned about that and would request an urgent ophthalmology review to look and make sure she doesn't have a keratitis. And because that is more urgent, we would also talk about what surgical options would have for her facial nerve palsy. So sometimes you can offer things like a partial tarsography or even gold weight to protect her cornea from further damage. Because if it's red and itchy at 3 months, then probably we haven't been getting appropriate eye care.
Right. That's excellent. Yeah, absolutely. And then Quincy, is there anything else you would do for this patient? So Gift is saying we need to get electrophysiologic testing, and we'll talk about that later. We definitely need to address her, obviously, her evolving ophthalmologic issues, which are now there. But is there anything else here that is concerning about the natural course of her disease that may force your hand or should force your hand into something else?
I'm looking at the STEM. Her initial evaluation, which did not include imaging, was negative. And given that there's been no resolution, I would do imaging to make sure there's no skull-based lesion or other lesion that I'm missing. I think that would be important, so to do an MR for her.
Yeah.
Activity. I think I would be considering.
No, that's excellent. That's exactly it. Yeah. So obviously you'd reevaluate her, right? So this goes back to the first key action statement, right? You've got to do your due diligence with a good exam and documentation, right? So much of what we manage in head neck things is it can be progressive, right? So it could be even something from a tympanic membrane perforation. You want to be very detailed in your documentation. Say this is a 10% central anterior inferior tympanic membrane perforation, right? So then you see them back, you want to be able to continue to document change, right? Same thing with this. Is really important to document her deficits, and then as you see her going across, then you've got a really good record of where was she and where is she going. And in this particular situation, yeah, you definitely would have her see the eye doctor, the ophthalmologist. Anything else you would offer? You've definitely recommended imaging. We presume that she's been on steroids, right? She's now 3 months out. So I'll just tell you that she's been on steroids and she did that whole thing. Is the indication for additional steroids at this point or any other procedures? Other than imaging, you did mention imaging. Anything else?
So there's been no proof benefit for additional steroids. Once they've got the initial high dose steroids, there are no studies that show that receiving either oral or IV steroids would actually improve the facial nerve function. If we did the imaging, we are looking for inflammation along the nerve. I personally haven't seen it, but I've had reports that on a T1 weighted imaging, you can actually pick up areas of inflammation along the nerve. Maybe we would consider facial nerve decompression.
Okay. So since you mentioned that, Amina, what segment of the facial nerve are you most concerned about? And if you were to do decompression, can you give me just some general instruction into how you would do that?
So in Bell's, we are mostly worried about the labyrinthine segment of the facial nerve. It's the narrowest, but it's also a watershed area, so it's commonly affected by inflammation. The approach is usually dictated by maybe the skill of the surgeon. If you have the easiest approach, I assume, would be a middle fossa approach, because that gives you direct access to follow the nerve from the internal auditory meatus labyrinthine segment to the geniculate ganglion. The alternative approach, which would be a transmastoid approach, would decompress, identify the mastoid segment of the facial nerve, either from the stylomastoid foramen or using other landmarks like the posterior canal wall, atriosemicircular canal, incus, short process of incus, follow the nerve to the geniculate ganglion, which the landmark in the middle ear would be your cochlear reform process. Then the labyrinthine segment takes a 70-degree turn from the geniculate ganglion. This still, it's not the easiest of surgeries to find the labyrinthine segment, and many times you would either need to take down the canal wall or perform it as part of a subtotal petrosectomy to give you access. But transmastoid, you take down your canal wall, identify your facial nerve from the gastric ridge, identify the mastoid segment, identify your tympanic segment to the geniculate ganglion, then the nerve will take a 70-degree turn to away from you towards the ISC, and it's just 6 millimeters. So the goal is to decompress the bone of the fallopian canal, but it's not the easiest of surgeries. But where the surgeon is skilled enough, then a middle fossa approach is also possible. And you follow the nerve from the internal auditory meatus to the labyrinthine segment and remove the bone around the nerve.
Mhm. Do you think that would be helpful at 3 months after the onset of the insult?
I don't know.
Yeah.
I don't know. I don't know. I think you need to have an
That's
honest,
like,
yes, and Brad is the expert here. I think you need to have an honest discussion with the patient. I don't see how this would help.
no, I would not. And honestly, and we'll talk more detail about this too, especially when I come and see you. Surgical decompression remains a controversial topic in this area because one, it requires a certain set of skills to do this, as you can imagine. And you're right, the transmastoid approach is not ideal, right? Because what did we say that almost all patients with Bell's palsy don't have that patients with, say, Ramsay Hunt or herpes zoster oticus have?
Hearing loss.
Hearing loss, right? So
Yeah.
Bell's doesn't really affect the hearing, right? So you are about to expose a patient to a highly complex surgical approach that is going to compromise something that they didn't have a loss in before, right? So that's something you have to consider. It's really challenging to sell that, and then you don't have a 100%. You're not certain that decompressing their nerve is going to help them, right? So that creates a conundrum there, right? Ethically. So, and then middle fossa is not, unless you're trained in that, that's a challenging thing because it lives right next to the cochlea. You're looking at temporal lobe injury, damaging the cochlea. Your drill could actually you could actually do more damage to the facial nerve than the natural sequelae of the disease, right? So there's a lot to that, which is why we'll talk about our recommendations here shortly, is we couldn't really make a recommendation about surgical decompression. Now that will be interesting as we look at the guideline update, but here are the recommendations. So you definitely need to reevaluate that patient. If they have either a worsening neurologic finding at any point from the onset, right? So if they start out at a 3 and you see them and they've gotten their steroids, et cetera, and then you follow them, and then actually they're regressing. Now they're climbing the House-Brackman scale. Now they're like a 4 or 5. Now the eye's not closing. Now, it's clearly worsening. You have to evaluate that person. Are they having new evolving ocular symptoms, or is it incompletely recovering at 3 months, or not showing meaningful recovery? Then you definitely have to reassess them for something else, because then you have to question your diagnosis from the beginning. Was it truly Bell's palsy? Or is it something else? Is it involving neoplasm of the facial nerve? Okay. But regardless, you got to reevaluate that person. And so surgical decompression, there's no recommendation made because one, it's not offered universally. Two, it's the standards are a little different. There's no standardization of it. And then the timing is critical. So it remains a possibility, but it's still controversial. And Brad, I'd love to hear your current take on this. What are your thoughts?
Sure. I grew up under the tutelage of Bruce Gantz, and Bruce and Steve Tillian, I think, were involved in a study looking at facial nerve decompression. And I have to say that Bruce was very much involved in a lot of middle fossa surgery because he took out all the tumors he could through the middle fossa. So he was very comfortable with that approach. But I think it's important to reiterate what you just said, that it's still not an easy approach, and it's not for those who don't do it often. And I think that study that he and Steve did, it's been such a long time ago that I don't know that other people who've looked at it. There's really not good data. I
Right.
agree with the recommendation of the committee clear back in whatever it was you guys did this 2013 or something. It's
Yeah.
been over 10 years since you looked at it.
Right.
I don't think there's strong evidence, but the thing that came out initially from that study that Steve and Bruce did was that if you're going to decompress it, you have to do it within the first 2 weeks.
Mhm.
So between 3 days and 2 weeks, when your ENOG goes out greater than 90%, then decompressing the nerve through the middle fossa approach to open the labyrinthine segment very carefully and not damage things showed a benefit of 1 to 2 House Brackman grades by doing it, which was
Yeah.
pretty minimal. And so
Yeah.
I think that if you were to kind of use a broad guideline, you'd say most people shouldn't do this. Maybe in selected centers where for some miracle you see them within the first 2 weeks, or which is very rare. As you mentioned last time, most times it's really unusual that you'd see a patient with facial palsy in a surgical setting in the first 2 weeks. So you could consider decompression. Um, it's very controversial, and I don't think it's been settled. It'd be interesting to see what the new guidelines come out with. I
Yeah.
just don't
Yeah.
think there's, I don't think there's a lot of new data that was done any better than the old studies, and the old studies are inconclusive. So there
Yeah.
you have it. Would I consider it for somebody? Yes. However, if you don't see them in those first 2 weeks, then I don't think it's probably a good idea.
Yeah. Yeah, exactly right. Thanks, Brad, for that. It's we'll talk more about it, Amina, when we're there, when we're going through some middle fossa approaches. But it's a challenging, you'll, as you're already aware, the middle fossa is a challenging approach anywhere, and to find the labyrinthine segment and to completely decompress in that area, it's definitely challenging. So this is a very nuanced sort of therapeutic, I would say, quote unquote. Yeah, Brad.
I have a quick anecdote to tell you about. I'll make this brief, but maybe the single most unpleasant activity that happened to me or that I was involved in my practice was when I was called upon to act as an expert witness in a case where a woman that worked at our hospital had a facial palsy that didn't resolve and didn't resolve and didn't resolve. And the neurologist who saw her at our hospital was sued by the woman because of her long-term facial nerve paralysis related to this Bell's palsy. And the expert witness on the other side of the trial was somebody who routinely did facial nerve biopsies for people with Bell's palsy.
Oh,
And I said, that's a very interesting stance to take. As a matter of fact, I said, in the course of the trial, I said, no other neurotologist in the country advocates facial nerve biopsy. And the opposing attorney said to me, are you accusing my witness of malpractice? I said, no other neurotologist in the country would recommend biopsying a facial nerve palsy patient. And it was just a very unpleasant circumstance. The jury found in the plaintiff's behalf because she looked so terrible. Really, the people who should have been sued were the plastic surgeons who did a terrible job trying to rehabilitate her face. They just made her look so unfortunately.
Wow.
It was
yeah.
a real mess. And like I say, it was the single most unpleasant experience in my medical career was being a professional witness against or in favor, actually trying to defend this neurologist who'd done everything he could. The bottom line was one of the folks there at Pittsburgh, guy who did initially believed in facial nerve decompressions, actually went in and explored her nerve and found a
Oh,
facial nerve neuroma, which was
hmm,
probably a regenerative neuroma in the labyrinthine segment.
yeah,
But anyway, it was a terrible case, and I felt terrible
yeah,
for the patient. But the neurologist did everything he possibly could to diagnose this. He referred her to neurosurgeons. He recommended, back in the day, this is before MRI was real great. He recommended an
yeah.
air contrast CT scan
Oh,
to
yeah,
see if an internal auditory canal tumor could be detected.
yeah,
She declined that.
no,
I thought he did everything reasonably possible, short of
yeah,
offering her a decompression himself, which he wouldn't have been qualified to do because he was a
right,
neurologist. But anyway, it was
yeah,
just a terrible story. So I'll end it there.
yeah,
But
yeah. Well, just, yeah. So Amina, guys, we don't advocate facial nerve biopsies.
no, don't do that. Even if Jack Pullock says it's a
Kind
good
of,
idea, don't do it.
yeah.
Oh,
It's
no,
kind
no.
of, yeah. It's kind of funny when,
And
oh, go ahead.
we also don't recommend transmastoid decompressions, and
No,
that's
no.
It's
because
a
you
lot
can't
of
get to the
muscle.
labyrinthine segment that way. Yeah.
Yeah, exactly. So yeah, so there's obviously no recommendation, but hold that thought. We'll have the updated guideline soon. Interestingly, acupuncture. So there's a lot of things in the literature that we're looking at now. Things like physical therapy for the face. There's different things that people are now involving that may be non-invasive. Interestingly, acupuncture has some space in the literature regarding rehabilitation for facial nerve paresis or paralysis. Again, no recommendation for this is also largely predicated upon a lack of standardization, right? So how do you standardize some of these practices where, you can truly, and so the literature is challenging on a lot of these things. So, but again, we're looking at all this too. So this will continue to be an interesting study in terms of what is maybe therapeutic. But again, no recommendation there. Interestingly, we'll be talking about more about there's an evolving support for literature about physical therapy. So people doing facial, kind of like therapeutics and exercises in an attempt to rejuvenate the face in these patients. Which again, we currently at that time of this guideline, but again, this is 12 years old now, which I can't believe that. We could not make a recommendation about that again because largely lack of standardization. Not to say that it won't be beneficial, but at that point, the strength of the literature was such that it was a bit more anecdotal or not standardized. Okay, so yeah, so these are the key action statements right here. So these were, again, so you want to do a good history and physical at the time of lab testing was not indicated. No diagnostic imaging except for if they're regressing or if you have some other concern, and Brad had mentioned, in the patient we saw in our caveat or our little clinical vignette was a 75-year-old. And so just to rule out any other things. So we didn't say routinely. So we said, don't routinely do this, which means you don't need jerk reflexively do it necessarily, but you reserve the right to offer that in circumstances that may be clinically indicating for that. Oral steroids for sure. No antiviral monotherapy. Definitely, combined therapy could be an option, and there's more literature now to suggest this. We'll be diving into that soon for the next guideline. Of course, eye care. No testing for partial paralysis or incomplete paralysis. Testing for paralysis for sure. Surgical decompression, acupuncture, physical therapy. We can't really make any recommendations about those. And then, of course, you're going to want to do a really good follow-up with these patients and make sure that they're not worsening or not evolving in their disease state. Okay. Questions about that? So as I mentioned, in 2 weeks, then, so in 3 weeks, let's put we'll do a full facial nerve discussion. How's that sound?
That sounds good.
Yeah.
I'll
Brad.
send out. Yes.
Yeah.
One thing that would be interesting to include in that is
Mhm.
alternatives to the House-Brackman grading
Yeah.
scale.
Yeah, right. We're going to, yeah, Brad, that's funny you bring that up. We've got a fair amount of folks on on the, um, the new committee that we were just at our first organizational meeting, we were just talking about that. Yeah, for sure. Cause it's obviously, as you know, it's not a perfect scale for this. So we have some wiggle room there. Plus also an interesting thing that's evolved obviously is some of the software animation that people are using now for facial nerve, particularly in the rehab settings, for things like synkinesis and different things like this. So there may be some interesting caveats to this. The other thing that we're looking at too, guys, is with the whole thing with vaccinations. We're going to discuss vaccinations. Is there any interest? Is there literature on that? And then the pediatric population. So we're going to be looking at potentially adding peds to this as well. So it'll be a bit more inclusive document.
Good.
Yeah. So
Look forward to it.
yeah. And then I know, Brad, we're kind of in the same situation where we don't see a lot of these folks in our clinics because either they've come through an ER or some other place, and then they're usually recovered, or if not, they're going to facial plastics. So as a neurotologist, I don't see these. I'll see Ramsey Hunt, because usually they might have a vestibulopathy or a hearing loss, which is a bit more relevant to our practices. Yeah. So I don't know. Do you guys, are you seeing many there?
No,
Have you guys seen
no,
many?
they usually will go, when they come to the emergency department, they get sent to neurology.
Right.
So they
Okay.
come to us if there is hearing loss, so neurology, and then they'll only send them to us if there is a Ramsey Hunt or something else, but it's not routine that we are seeing them.
Mm-hmm. Yeah. Okay. All right. Well, great to see you guys. Have a great weekend. Julie, thanks for joining. As I mentioned, you'll meet, Julie's coming to Cape Town for a few days. So she's spent some time with us. And then we'll talk a little bit more about her organization and what's going on there. So.
All right.
Thank you for including me. I'm really excited to meet you.